Great. Other questions from the panel, either here or online? Questions and input on any of the talks now. This is the end of our first portion, so we can go back to any of the topics and questions.
I want to go to that point about the intubation for not having the pediatric residents even more so. In medicine, I think that's changing across the board. If I'm doing a thoracoscopic esophageal atresia case, I'm not going to let a general surgery resident do the anastomosis, where we used to. I mean, when we trained, we did everything. But if they're not going to go into pediatric surgery, they're not going to be touching that anastomosis. And I think we need to do that more and more. In the operating room, all the time, in the OR, it's not the anesthesiologist, it's not the CRNA, it's a medical student or someone else intubating. I think that's ridiculous. You know, they can learn to intubate when they decide to go into a profession that they're going to be intubating. And we've got to use those intubations to train the people that need to be intubating. And intubating is one of those things that we love to let people try, right? It's like the thing. It's like, oh, I got to intubate today. No, that needs to stop, in my opinion.
Yeah, we completely agree with that. The vast majority of pediatric residents will never perform an intubation once they graduate. And so actually in the last year, we always wanted the pediatric residents to have, because they do participate in every single resuscitation. They're the bedside, they're doc left in every single patient. So we didn't want to completely remove them cognitively from the process. They're an important contributor to the success of the process.
Yeah.
So what we've done in the last 2 years is we've said to the peds residents, if you have decided you want to go into a critical care fellowship or into emergency medicine,
right,
then you can come and do some dedicated simulation-based training.
Yep.
And you can execute the checklist. And then if it's a certain type of patient, meaning a lower risk for desaturation, you can have the first attempt. So by doing that, we have narrowed that pool of 100 and whatever pediatric residents down to 10. And those 10 people, in addition to being very motivated, are much more likely to actually use the skill and probably be better at it even in the ED in the future.
So more and more I'm seeing these video laryngoscopes being put into practice. I remember when they first came out, it was like a cool thing, and now they're actually kind of all over the place. Is there something that we should know about that for all the people out there who, I'm curious how many people even have that at their institution? I'm trying to figure out how to do this without having any CME violations, but can we talk about what the options are out there and what what we need to know to look for and what makes a good video laryngoscope? How much do they cost? How practical is it to have it? Can we be doing this always, or is that not practical?
How much time do you have, man?
How about 30 seconds?
30 seconds, all right. Well, there's no question that a video laryngoscope is becoming, at least in emergency medicine, standard. So there are, and certainly that's going to be true to begin with in academic centers. It's a standard thing to have.
Okay.
Whether or not it's the first thing you do, that I think is still debatable.
Okay.
The essential thing, though, to understand about how we used it and its primary benefit when you're doing intubations relatively rarely, whatever that, and that's a subjective description, is it gives the care team, the supervisor and the other care team, essential information about the procedure they otherwise wouldn't have had. So you both can recognize when someone is struggling and or failing.
Yep.
And more importantly, you can know why they're failing. So
Yep.
you can see the tube's too big.
Mm-hmm.
You can see that they're not positioning the airway appropriately. You can see that they have no idea what they're doing and they need to be pulled away from the airway.
What's the most common mistake they're making, by the way?
The most common mistake they used to make is just not knowing well enough how to do it. Now that we've taken some of the peds resident outs and we've peds residents out and brought other people in, or given more attempts really to the pediatric emergency medicine fellows, I would say that just basic airway positioning stuff is still the most common problem.
And Ben, I would add that in the importance of it being a sterile procedure, meaning that everyone needs to be quiet, there shouldn't be any extra noise, and certainly for the operator of the laryngoscope, your view is different than the person standing next to you, and so you have to be cognizant of that. So if people are kind of breaking the sterile procedure and they're coaching you, oh, I see it, it's the anterior, well, their view is a little actually a little more anterior than the operator. So as the operator, you have to decide, are you going to look through the laryngoscope, or are you going to look on the screen? In our bay, we can actually, in bay 2, we can see it up on a big screen, or we can look to the laryngoscope screen. But those are two important points.
That's a great, so
that I've noticed.
I'm sorry, so what are you supposed to do? There's no right or wrong answer?
Whatever you're most comfortable with. And that's where it goes to simulation, because if you can practice and you know what you're comfortable with, then that's what you should do.
Wow. Okay.
So one thing I can comment on that Ben, I know struggled with initially, at least from some of my partners and some of the other surgeons, as far as how much longer does this take? Does using the checklist slow down the process? And I think that's certainly come up in other surgical arenas, doing a pre-op checklist, and what's the impact of taking that time? And there's certainly growing more and more evidence that the value of taking that brief time to do a checklist has advantages. As I mentioned, we use anesthesiologists for most of our trauma intubations, as you know. Can you share, and I know you've looked at some of this data, kind of the impact even in that group on the benefits of the checklist and the impact, positive or negative, on how much time an intubation takes?
Right. Well, the thing, in order for a cognitive aid like the checklist to be beneficial, both in terms of efficiency and procedural success, there has to be complexity. So if you're in an environment where you're seeing, 1,000 airways a year, so there are some adult centers, academic adult emergency departments that will intubate over 1,000 patients in a year. If you're in that place, it may still be true that standardization would help you, but it's not nearly as important, and it's not nearly as big a gap as in a place like us, where we're doing we were doing 120, now we're doing maybe 75 a year. Again, individual provider experience is just not enough. Meaning you cannot get to expertise or mastery just based on seeing enough cases. They aren't there to do. So in that setting, you have to, I think anyway, standardize your procedure. And of course, one of the things when we started out, people would ask was, well, aren't you going to make this so much? This feels clunky. We want to get the tube. And what we find is that being quote unquote slower makes you smoother, and smoother makes you faster. That's kind of a mantra. Versus if you compare sort of taking the time it takes to do the checklist, it's about 3 minutes on average for first attempt success. Using the checklist, unfortunately, or maybe fortunately, we use the checklist for 95% of patients now, and so we don't really have data to compare. But if you compared that to before, it was maybe about 4 minutes. So specifically, we've gained about a minute. And the main reason we've gained that, I think, Rich, is because if you don't use the checklist in our setting and you have problems, certainly it's going to take a heck of a lot longer if you're missing attempts, having esophageal intubations, having desaturations, making the patient vomit, than if you use our checklist and slow down just enough to do it right.
Great. It certainly has seemed to allow us to actually give the medications, give them time to work, or I think certainly even with a skilled intubator, from a technical standpoint, was very good. Experienced anesthesiologists, we still weren't always waiting enough time for the medications to actually work before that first attempt. We'll spend the afternoon talking about brain injury. Obviously, that increased ICP of stressing that kid. There was a question here from the audience about preferred induction and paralytic agents for pediatric RSI. So you want to comment on what we do and what your thoughts are?
So medications I'm not totally sure, often become one of the main things we discuss when we talk about our work. And I honestly don't care that much about which medications are used. I care about how they're given, especially in relation to the rest of the process. There are absolutely nuances. There are absolutely reasons one might be better than another. A lot of people don't like succinylcholine for many reasons, some of them very good. People prefer rocuronium. People don't like etomidate for good reasons. They like ketamine. There are all sorts of nuances to the medications, but I'd answer the question by saying we use succinylcholine and etomidate for 70% of our cases. But we also use rocuronium and fentanyl and ketamine. We have other options available. But I care way less about what medication was used than about how it was given, meaning was it given rapidly and in succession, not over a 5-minute period? Was it, and then do we wait enough time after the paralytic to allow the patient to be paralyzed or not move and not breathing anymore. Those sort of things. Did we redose the medication? So, did we wait too long and try a third attempt and now we're failing because the kid's moving because the sucks is worn off? Are we giving a paralytic when the patient is still awake? These sorts of things are way more important to me than the nuances of medication selection.
Great, thanks. I just want to bring it back before we break for the afternoon. It's unusual for me to see 3 neurosurgeons in the same room at the same time, none of who have chimed in and voiced an opinion yet. So I want to kind of open it up. I know Dr. Piat's going to start our next session talking about C-spine evaluation and clearance, but any input from any of you on kind of the ideas of not immobilizing these kids prior to them coming in, your concerns or your encouragement of looking at that. I think the audience would be interested in hearing some more.
And make sure you unmute your mic.
I'd like to ask a question to Dr. Brown about the, it looks like it was a protocol when the patient first came in. The patient was sent for multiple scans, a CT scan of the head and of the abdomen and pelvis, and also plain films of the cervical spine. Is that a protocol that is typically done at your institution? And does it vary depending on age? And hopefully Dr. Pyatt will talk about this a little bit in his presentation as well.
I think it varies depending on age, but in general, a patient that we're suspicious for a brain injury, we would get a CT of the head, and since we can't really evaluate the belly because of the, obviously this patient had a distended tender belly, but they're going to get a CT of the abdomen and pelvis. And we tend not to get a CT of the C-spine initially with most of our children. We'll get the C-spine films first. So.
And who reads those films? Are they read by a dedicated pediatric radiologist, or and how quickly do you get the responses back?
We get a response very, very quickly. We have radiologists pretty much in-house 24/7, and so we get an immediate response.
And they're all pediatric?
Pediatric radiologists that are here.
So certainly we have a bias because we have that access. I think it certainly varies based on who's reading, as you're alluding to, kind of who's reading your films and whether you trust that read initially or not. We've also just found that most of these kids, and I know Dr. Piat will touch on this, but most of these kids end up going back for a follow-up head CT the next day, leaving them in that C-collar and evaluating the next day when things are otherwise more settled. If you need to get that CT, we find is a useful time. Some of those kids will wake up and be able to be cleared without any other imaging, and if they're not, then you move forward with some imaging. So that's our general pathway.
I have a comment about the clinical case that was presented. Children, particularly small children who need CPR at the scene after head trauma, we should think about occipitocervical separation. It's an extremely unstable injury, and it's an injury that detected early in the evaluation process so that intelligent decisions can be made on a number of levels. So just a short circuit for your thought processes. CPR at the scene, think about occipitocervical separation.
Great point.
I think on this case, we were especially surprised whenever this patient with the severe head injury and so forth did not come in a C-collar as well, even when they were brought in by EMS.
So I think it brings up the point. There's certainly, Hamilton, you can comment. I mean, there's certainly times where not immobilizing may turn out to be the right thing, but there's also going to be times like this where a high degree of suspicion warrants some sort of immobilization.
Yeah. I mean, I don't want to give any impression that with the case that was presented, full spinal mobilization was not indicated, and I think that regardless of whether you looked at the American College of Surgeons recommendations with the American College of Emergency Physicians and American College of Surgeons recommendations, you take PEP. All those would have recommended immobilization of the child presented in the in this scenario. Primarily, obviously, the controversy is around those children that are of minor mechanisms and ones where a majority of people would say, "Gosh, I don't really think this kid has an injury." So I don't want to give want to give that impression that the field of EMS is looking to immobilize no one, just the appropriate people with evidence-based tools to decide which ones really need them and who don't.
No, thanks. I think making that clarification for everybody, I think, is important, because I think it's just like in pediatric surgery and pediatrics in general, we try to reduce imaging, right? We're trying to minimize imaging, but we also have to realize imaging is an incredible, valuable tool, and at times you need to know when to use it rather than pan scanning everybody and reflexively imaging. But we don't want to get away from, there are certainly patients that need to be immobilized. There are certainly patients that need to be imaged. We just need to help people understand what are the right groups. All right. So if there's no other comments or questions right now, I think we'll take our break and resume around 2 o'clock.
Yeah.
And
Perfect. Extra
continue
time.
with the afternoon session, where we'll focus on cervical spine, which we've alluded to. We'll have Dr. Adelson with us to talk about operative intervention. We'll hear about some clinical guidelines for TBI and how to do that better, and then end with some pediatric rehabilitation and some follow-up questions. So we'll see you shortly.